The part 2 of the 2 lectures on acute aorta will today cover everything but acute aortic dissection. So that includes intramural hematoma, penetrating atherosclerotic ulcer, and then what I think is also falls under this category is rupturing thoracic aortic aneurysms. So all of these we will cover in the next hour or so. And then finally, we'll have probably some time to discuss the classification of acute aortic syndromes and just make some clarifications, mostly how these different entities are connected to each other, and what are the similarities and the differences, because there's a lot of confusing statements in the literature, for example, stating that, I don't know, an IMH can become an PAU and the PAU can become a dissection and all kinds of stuff. So I hope we'll be able to clarify this at the end of this talk. So we'll start with the first case, and this is a 62-year-old man with hypercholesterolemia and hypertension, and he presents to the ED with chest pain. And before instituting any IV lysis, then the ED required or requested here a CT scan, and that's, as I think everybody recognizes, is an acute intramural hematoma. And we've seen these images yesterday, and the hallmark is again that you have a crescent-shaped zone within the aortic wall, which is hyper attenuating relative to the blood pool. So the blood pool is always lower in attenuation than fresh clot. And the reason is that fresh thrombus doesn't have too much iron in there, and that's why it's hyperdense, which is what I thought initially. But the reason why clot is hyperdense is because it's concentrated hemoglobin, essentially. You have essentially a high protein concentration, which gives it a higher attenuation on CT. And you also see a little bit of a lower attenuation line here, which reflects a slightly thickened, probably atherosclerotic or non-calcified atherosclerotic plaque sitting on the intima. And you see the same changes here. So there's quite a thick intramural hematoma in the ascending and descending aorta. That's a type A intramural hematoma. Nobody will dispute that, and I think that's very clear. And if you make the window narrower, then you can see it even better. And again, the assumption is that if you extend from the classic dissection, we have a similar situation in this particular patient, because these patients also have a similar underlying media disease. So again, you also have to have cystic media necrosis. You have to have a potential space within the media so that that space can, in fact, get delaminated. But instead of having a primary intimal tear and an exit tear, and you have a true and a false lumen and a new channel running within the aortic wall, in the case of intramural hematoma, you have blood rushing into the aortic wall, but it doesn't get out, and it sits there and it coagulates, and then you have blood first, but then you have clot subsequently, and that's what looks like an intramural hematoma. But again, for most of those patients, the underlying pathology is very similar. So you need to have underlying cystic media degeneration or some media degeneration to allow these kind of intramural hematomas to develop if they are among the dissection spectrum. So again, so this is very clear. Nobody's going to dispute that, but the difficulty comes once you have contrast on board. And again, these images here are what you would expect, because the aortic wall, the intramural hematoma, does not enhance with contrast. And so you see a thick wall, but we know from the non-cons that is in fact fresh clot. Also straightforward. But what's confusing is once you look at all the other images, and maybe even in some of the reformations, because when you go up to the level of the proximal descending aorta, so this little outpouching here corresponds to this lesion here. So what we see here is a small amount of contrast that's within the intramural hematoma here. And then if you go a little bit lower, you see a linear contrast filling here that runs in the intramural hematoma. Oh, there's another one a little bit lower. And if you look even lower, we see another little puddle of contrast that sits within the intramural hematoma. Okay, and that usually causes a lot of confusion because the question is what that is. Because if you follow a traditional definition of intramural hematoma, the original definition said that it's thrombus within the wall of the aorta without communication with the true lumen. And we see, I don't know, at least 1, 2, 3, 4, I don't know, 4 communications between the true lumen, the contrast here, and the intramural hematoma. So do you say, well, is it, maybe it's not an IMH? Some people have called as well, maybe this is a PAU, a penetrating atherosclerotic ulcer, or maybe other people have said, well, maybe this is an endoleak or something. But I would argue that what you see here is almost on a regular basis something that you will observe in patients with intramural hematoma. And I would think that the most proximal lesion here is just the equivalent of a primary intima tear, as you can see it in the aortic dissection. For some reason, it's smaller. And once the blood got into that false lumen, it probably rushed down here, the descending thoracic aorta. Maybe it didn't find an outflow where the blood could rush out again, and so it just coagulated. Okay, then you may wonder, well, what are all these other little puddles here? And if you look very carefully, you can see that most of them do connect to intercostal arteries. And that's explained simply by the fact that if you rip off an intima layer or an intima media layer of the remainder of the aortic wall, in a location where you had an intercostal artery ostium, you will have to have a little hole or a little perforation in that intercostal branch. So remember, when we looked at a larger artery yesterday, like the right renal artery, then as soon as you rip off an inner layer of the aortic wall from an area where you have a branch vessel, then there has to be a hole in that membrane because it pre-existed, because this piece here originally connected to that. So if it's not a large renal artery, but a small intercostal artery, you will expect to find tiny little holes here that are sheared off ostia of the intercostal arteries. And sometimes the blood just finds a little puddle, the little way through that intramural hematoma to still get some blood into those branch vessels. Okay. So here are a couple of other examples. These are all from different patients, and they can come in all kinds of sizes and shapes. So the communications are usually really small because, again, those are intercostal artery origins where then blood gets into this puddle in the IMH and then it communicates to an intercostal artery or a bronchial artery, or it could also be like an esophageal branch. And then this one is a little bit larger. So what can happen is that some of those lesions can be a little bit larger. And once they are larger than 3 millimeters, these little ulcers, like, or these defects, then they have a more ominous prognosis than just these little puddles. So these little puddles you will see all the time, and you would have to expect them if you have a good enough CT scan. So I think the best paper that has been published recently that really looked in more detail of these focal intima disruptions is from Arturo Evangelista's group. So he is from Barcelona in Spain, and the other half of the co-authors are from Argentina. And the reason why this paper is really good is because it's a prospective study. So they really managed to prospectively enroll 107 patients with type B IMH out of 700 acute aortic syndromes over also more than 10 years. So that's really quite an accomplishment. And so what they found is that if patients had what they now refer to as focal intima disruptions, and focal intima disruptions they define as those larger lesions, so those that are larger than 3 millimeters. So the smaller than 3 millimeters are the little fenestrations or intercostal artery communications. But once you have those that are a little bit larger, like more than 3 millimeter, then, and if they develop within the first few days, they turned out to have a bad outcome. So outcomes here, endpoints were any aortic disease-related mortality or overall mortality, and complications that required either surgical or endovascular repair. So again, just as a reminder, it did not include the tiny fenestrations that we were talking about. We see this all the time, and these probably have a relatively benign prognosis. Yeah, so you see these tiny little puddles here. There are some echo correlations as well. So they were talking about those larger lesions that we had mentioned. And so what they found is from those patients, about more than 10% had these focal intima disruptions, and almost all of them had events. So if you have a larger intima disruption, that's probably a bad sign. And if it happened in the later phase, it wasn't really a major issue. Again, just the summary is that if you have these tiny communications that correspond to intercostals, those are probably relatively benign. But once you have these ulcers or ulcer-like lesions or intima defects that are larger than 3 millimeters, those are probably a sign of bad outcomes. And here's an example of a patient who had a similar lesion from our own collection here. So this patient here has also, you can see a big fat intramural hematoma here in the arch, in the ascending aorta, again, extending in the descending aorta. Again, as long as as soon as the ascending aorta is involved, we would call it type A, IMH, even if the primary lesion is probably somewhat more distal. This is probably in the distal arch here. And this is probably more than 3 millimeter, and this does not truly seem to connect to an intercostal or bronchial artery. So this might be one of these larger lesions here. And again, you wouldn't necessarily treat it immediately, but you probably have to follow this carefully at closer intervals. So usually these patients are admitted, and before they go home, as you can do a pre-discharge scan or scan them after 2 weeks to make sure that nothing bad happens if you decide not to treat the ascending aorta. And interesting what happened here, this is January, this is 2 months later. You see in 2 months, this little lesion got bigger, and even the little ostium got bigger, and you have 2 new puddles which have developed in that aorta despite the thickness of the IMH has actually gone down. You see here the IMH is actually smaller, but this little lesion, this outpouching, did get bigger. So again, the total diameter wasn't really that large, but then we just did a short follow-up, like I think this is just like 3 weeks later, and now you see a coalescence of these lesions here. And again, a few days later, ultimately this became like one large outpouching. You could consider this all one large false lumen, if you want. So that's a consequence of one of these larger focal intima disruptions. So they really can behave badly and have a bad prognosis. So this patient was ultimately then treated with, you see here the lesion from below. You see this large outpouching here, the supra-arch vessels, and after her type A repair. So again, so the summary here, the most important thing, the takeaway point here is that while the traditional definition of intramural hematoma, in contradistinction to aortic dissection, that it is defined as blood or clot within the aortic media and the absence of a direct communication with a true and the false lumen. So there shouldn't be a tear or no dissection flap or no flow. But truly the current understanding or the modern view of intramural hematoma is that communications between the true and the false lumen or that false lumen space often exist. And those could either be probably small primary intima tears, it could be these small side branch communications or branch arteries, pseudoaneurysms, or natural fenestrations, which are relatively benign, and we have to expect them because if a side branch exists, pre-exists, there has to be a little hole if that wall gets torn off. And if we have larger lesions with intima disruptions or new tears, those usually have a bad prognosis or a more have a worse prognosis than not. So that, I think, is really the main message of intramural hematoma imaging findings in these days. Now, here's a couple of other challenging questions to make some clarifications or clarify some of the issues. So this patient is a 67-year-old woman with an intramural hematoma, and you can see on the post-contrast scan, at least it does look like IMH. You see the contrast here. This is proximal descending aorta. Again, this is not arch, this is descending aorta because arch vessels are here. So we are just in this arching area of the descending thoracic aorta. And when you look at the non-contrast scan, it doesn't really look that bright. And then you would say, well, didn't you just tell us a few minutes ago that an intramural hematoma has to be bright on non-contrast scans, because otherwise it's not a fresh intramural hematoma, because it's the clot that is so dense that makes it visible on CT. And again, if you just look at the area of the contrast-enhanced scans corresponding to the same area on the non-con, you can see that it is not hyper-attenuating. So what's going on here? So there are a couple of possibilities. So first of all, theoretically, this could be flowing blood, and that just opacifies very late, so it's just not clot yet. But the more likely explanation is that it's maybe the intramural hematoma is not totally fresh. So you could it could be an older IMH. Another pitfall could be that the patient maybe had some intravenous contrast for, I don't know, for a head and neck CT angio or for some other reason a few hours ago, and so the blood is the blood is actually not completely low attenuation as it should be. But in this case, so again, if you just think about what the CT density of blood and clot is on non-contrast CT, and that's really something, this is like CT 1972, right? So this is CT 101, so that the blood attenuation is hematocrit dependent. It's 20 to 30 Hounsfield units, so it's usually higher than so it is unopacified. This is unopacified blood and blood that is not clotted. But once you have thrombus, it gets up to 50 or 80 Hounsfield units, and the reason is because they're retracting fibrin fibers. They concentrate hemoglobin. But then it doesn't stop there, because after about 10 days, usually the hemoglobin resolves, or you have hemolysis within that clot. And once the hemoglobin concentration goes down, then the thick, what looks a thick wall is no longer is no longer hyperdense, so it will decrease in attenuation. So chronic clot, so then it becomes isodense. So chronic clot is what you see as a chronic thrombus within a AAA, for example, is always low in attenuation. It's always lower in attenuation than the blood pool, as you'll see in all these AAAs that we saw in our CTAs of AAA patients. So pitfalls are, for example, if a patient is very anemic, because if a patient is very anemic, then even a standard clot can look hyperdense, because then the clot looks hyper in attenuation than the very low attenuation of the blood pool. And if you have residual contrast on board, and the reference that are usually used to gauge the degree of the blood pool, if it's normal or not normal, is just to look at the myocardium on the non-contrast scan. So in this case, we just found an older study, so this patient was transferred because of ongoing symptoms after a few days, but the patient had an IMH at least 7 days prior, so you can expect that in 7 days, that relatively fresh thrombus will no longer be hyperdense, because hemolysis has set in within that clot, so it can be iso-attenuating to clot. So if you only a very fresh intramural hematoma will be hyper-attenuating, so after 7 to 10 days, it will no longer be hyper-attenuating. And you can see here after 2 months, this whole IMH has completely resolved. So that's the ideal outcome of a patient who has an acute intramural hematoma. that it completely resolves and the wall may be a little bit thick here, but if you only had these images here, you wouldn't be able to tell that the patient had a prior IMH. You could argue, well, this just looks like athero. Okay. Treatment of intramural hematoma in general, if the ascending aorta is involved, it usually favors surgical treatment. Like in Korea or Japan, it's usually they are more conservative and just scan the patients more often, and if they are not symptomatic. But here, usually type A, also ascending involvement, usually prompts a surgery. Whereas if the IMH is confined to the descending thoracic aorta or arch in descending thoracic aorta, so type B, then usually it's managed medically. And again, unless there is complications, so if there's recurrent pain, refractory chest pain, or evidence of progression, etc., then again, these patients are typically treated with endograft. Here's an example. There's a patient who has a type A intramural hematoma. You see this crescent-shaped hyperattenuating zone here in the descending aorta and also in the ascending aorta, all the way going down to the aortic root. And then another ominous sign is always if you have slightly hyperattenuating fluid in the pericardial space. So that's usually suspicious that something's going on in the ascending aorta. And again, one thing I want to make clear is that you don't have to have an rupture of the ascending aorta to have some pericardial fluid or even hemorrhagic fluid in the pericardial space. It is enough to have blood within the media, or if you have a dissection too, it doesn't have to rupture to get fluid in the pericardial space, because the only truly blood-tight layer in the aorta is the intima. So if the intima is gone, or if the intima is violated, or you have blood under the intima, which means in the media, you will have some fluid from the blood seeping through the residual wall, which is not totally blood-tight. So, and that fluid gets trapped in the pericardial space. But this happens usually relatively slowly. It doesn't result necessarily in acute massive tamponade. If you had a rupture of the aortic wall through the adventitia, this is very hard to survive if you have an acute tamponade of the pericardium. So if you have fluid that seeps through the wall in the descending aorta or in the arch, then you will see periaortic stranding, because then that fluid seeps into the periaortic soft tissue and in the fat, but you won't have a pericardial fluid. This patient was treated with an interposition graft, and they also did some resuspension of the valve. Again, as I mentioned, this is called an interposition graft or a supracoronary tube graft repair. It all refers to the same technique, that you just repair or replace a short segment here of the ascending aorta, and the remainder of the descending aorta you can just leave alone. And this looks very good post-operatively. You have the ascending aorta repaired, and you still have a residual IMH in the descending aorta, but there's a good chance that it's gonna resolve. At least that's what you would hope. But again, it turns out that this patient came back just 6 months later, and here you can see what happened to the descending aorta. You can see there's descending aorta has overall grown substantially in size, so it become aneurysmal. There's still may either be a new IMH or still part of the original IMH, but usually it would get thinner. Now you have a new intima defect here, and you even have like a two filling defects here. So you wonder if this is a partial thickness tear of that false lumen. So this is a dramatic increase of the aortic size. So this can happen in these intramural hematomas. They can evolve relatively quickly, and this one I would argue even ruptured, because now you have in fact a little hemorrhagic pleural fluid. So that's a very traumatic situation. So the type A was fixed, but again, IMHs are not always benign. So this was then subsequently fixed with an endograft from the proximal descending all the way down to the supraceliac descending thoracic aorta. So the prognosis of IMH is really a bit variable. So overall, it's a bit better than acute aortic dissection. And again, type A is always much worse than type B. But there is a certain number of patients who do progress to a full-blown aortic dissection. Usually it's in the early phase, and some of them completely resolve. And the late phase is also a little bit better, but depending on if they were initially progressing or not. So those patients in whom the IMH completely resolves, they do very well. And some of them, we still have them in our surveillance program. They still come for follow-ups every year because you don't want to miss anything new happening, but usually they stay very stable. So we looked at some of the IMH patients from our own cohort here, and the main message is that those patients in whom the IMH resorbed completely, they really had essentially no events. So, and they were had a very good prognosis. But if there was progression, like we have these ulcers develop, or the false lumen was, or the aortic diameter was growing, or anything going on, then they had a worse prognosis. It looked even worse than acute dissection, although that was not statistically significant here. But the other main observation is that if the IMH progress, it usually happens in the first year. So our surgeons are relatively liberal in ordering follow-up studies for these patients early on. So they usually have at least this 3-month, 6-month, 12-month study to make sure that nothing happens in the first time. So these IMHs are not totally benign. They can completely resolve, but they can also behave very malignant. So when you read a patient with an intramural hematoma, what are you gonna put in your report? What's most important first is always you wanna distinguish between type A and type B. So is the ascending aorta involved or not? Because type A usually needs to go to surgery, or at least needs a cardiothoracic surgery consult. Then if you have an IMH, you wanna see if you see the location where the blood enters the aortic wall, and it could be either a PAU or an intimal tear, which I'll discuss in a moment. And you always want to look for signs of rupture, because that obviously increases the urgency of treating that, even if the ascending aorta is not involved. So just one clarification in terms of what intramural hematoma means, because this has confused me for many, many years, and in the literature. And so let me just explain what intramural hematoma can mean in the literature and how people use it, because it turns out that intramural hematoma really can have two separate meanings, and people or authors don't let you know always which kind of IMH they are talking about. So you have to try to distinguish this by yourself. So the number one, you will encounter the term intramural hematoma as one of the variants of aortic dissection. So that means this is patients who have a very similar risk profile as the patients with aortic dissections, like those we discussed yesterday. But those are patients who have cystic media disease and who have essentially a potential space where blood can rush in. And it can extend from the ascending all the way down to the descending aorta. They look from the extent exactly the same like aortic dissections, but for some reason, they don't develop a true lumen and a false lumen, but they develop a true lumen and a thrombosed false lumen. Okay, so these patients overlap with their history, with their demographics, with classic dissection patients. They're just a little bit older, and sometimes they have No, they also have the same, they don't have aneurysms or anything. So they're just a little bit older than a patient with acute aortic dissection. But they all have histologically cystic media degeneration, okay? But the confusing part is that the term intramural hematoma is also used in a very generic sense, meaning just that it's blood in the aortic wall, which translates into Latin intramural hematoma, if you want. Yeah. And you can obviously have blood within the aortic wall whenever you have a disruption of the intimal layers of the aorta. So you can have an IMH or intramural blood associated with a PAU. You can even have intramural blood associated with a rupturing aneurysm or even with trauma. And this has nothing to do with patients who have cystic media disease. This just what you have a focal blood that accumulates in the aortic wall whenever you have a disruption of the luminal surface of the aorta. Okay, but it does not mean that if you have a PAU, that it can evolve into an aortic dissection, right? This is not what it means, right? So an IMH can mean a dissection variant, or it's a very generic term for just meaning blood in the aortic wall. And it is to some extent justified because if you have fresh blood in the aortic wall, which means hyperattenuating blood, it always means that it's an acute process. And since the treatment of many of these processes overlap or are kind of similar, it is kind of justified to still keep this terminology, but just keep in mind that there are these two separate meanings of this term in the literature and also how imagers or clinicians use it. And I think what happens is that everybody is confused at first, but then they learn how to use it and how everybody else uses it, and they don't bother anymore to differentiate it. And so every newcomer again has to go again through the phase of going through this confusion by him or herself. Okay, now the next topic is the penetrating atherosclerotic ulcer that also results in a lot of confusion in terminology and clinical presentation and imaging findings. So the main thing to understand about atherosclerotic ulcers is, again, some clinical background here is that these patients are different than dissection patients. So patients who have penetrating atherosclerotic ulcers are the vascular path. So those are the patients who have severe athero. So first of all, PAUs are less common than dissections. They have a high risk of rupture, so they are quite malignant lesions. They are almost exclusively in the descending thoracic aorta. They are often multiple, with extensive atherosclerotic changes associated with it. The patients are typically older, so they're about a decade or more older than patients with dissections. In our cohort, it was about almost 15 years older. And they have all more risk factors and comorbidities, and they have all the atherosclerotic risk factors. So they all have hypertension. Many of them have a chronic kidney disease, history of coronary artery disease, peripheral artery disease, cerebral vascular disease, and many of them have AAAs or thoracic aortic aneurysms. So those are the severe vascular path. So it's not dissection patients who are, 60 years old and have untreated hypertension. Those are patients who have very manifest atherosclerotic disease. And this is such a patient, a 73-year-old man. And if you look at the axial images, you just look at the atherosclerotic changes that this patient has. He has a penetrating atherosclerotic ulcer with a large thrombosed pseudoaneurysm, but he has athero everywhere. I mean, look at this one here. This is extensive clot. And in some of those thrombos or clot, you see, in the mural clot, you see also ulcers. There are multiple ulcers within that patient's atherosclerotic plaque. And some of them penetrate through the wall and become penetrating atherosclerotic ulcers. So those of you who ever did a pathology rotation during training and had to use scissors to cut open an atherosclerotic ulcer will remember that it's very crunchy to cut this open. It's like, it has all this crunchy sound when you cut this open because there's all this calcium and there's stuff in there. So that's the patients who have penetrating atherosclerotic ulcers. And again, to have it in the big picture, to find out what we're really talking about, because the acute penetrating atherosclerotic ulcers, this is what we found all so dramatic, and this is what can be causing or presenting as an acute aortic syndrome. But the big picture of acute penetrating atherosclerotic ulcer is that it's a small spectrum of all the atherosclerotic changes that you can see in patients with severe atherosclerosis. And a penetrating atherosclerotic ulcer is just the deeper version of the atherosclerotic plaque or the ulcerated plaque. And that's much, much more common. I don't know, 100 times more or 1,000 times more common. Again, keep in mind, an atherosclerotic plaque can sit obviously in the carotids, in the coronary arteries, or also in the aorta or anywhere else. And atherosclerotic plaque tends to ulcerate. So you can have plaques that ulcerate, and if it's unlucky and the plaque ulcerates in the coronary arteries and the lipid core triggers a thrombus formation, then the patient develops an acute myocardial infarction. And you have similar situations. You can have patients who develop stroke or TIAs or atheroembolism. So if you can have acute ruptured or ulcerated plaque, the complications are usually downstream embolic events, okay? But then there are many, many more chronic atherosclerotic plaques and ulcers because they re-endothelialize and they sit there, and you see them in the aorta, you see them in the coronary arteries. This is where calcified plaque comes from. It's healed plaque. It's inflammation after maybe a plaque has been ruptured. So all of this happens within the intima, and all of this happens within the thick intima within that plaque. So if one of these ulcers happens to penetrate through the internal elastic lamina into the media, then it's called an acute penetrating atherosclerotic ulcer. Now here's a cartoon that represents that. So under normal circumstances, you have intima, media, and adventitia, and again, the media is exaggerated here as the thickest part. But if you have a patient with severe atherosclerosis, then it's usually the intima which is very, very thick. And if you have an ulcer within the intima, then we talk about an ulcerated plaque. And if it happens acutely and you have downstream embolic events, it can result in some acute complications, okay? But it's still confined to the intima. And here's how such an atherosclerotic plaque can look like, and it really reminds us very much of a stomach ulcer, right? There's really ugly looking undermined edges here. So this is how an atherosclerotic plaque looks in a very thick intima. So this is very thick intima in this patient with atherosclerosis. So here's a patient who is referred for a chest, abdomen, pelvis, and run-off CT angio to rule out atheroembolism. So the patient has what's called a blue toe syndrome. So usually this means that you have microembolic events to the peripheral vasculature. It's a very typical clinical picture when you ever see those patients. And the only finding that we see here is this here. You do see something that looks like a thickening of the wall. So this could be atherosclerotic plaque. And I would say we see a little ulcer here. So what do you think that is? Or could we explain this anything? So could this be an acute penetrating atherosclerotic ulcer? Or is this a small atherosclerotic ulcer that causes distal embolism? Or is this just a focal dissection? And I think you all know the answer, that this could very well be a small atherosclerotic ulcer that causes distal embolism, which is the blue toe syndrome. So this is not a penetrating atherosclerotic ulcer because it's confined just to the intima. If it was a penetrating atherosclerotic ulcer, we would either see a local IMH or the patient would have symptoms from his aorta and not from downstream And obviously, this is not a focal dissection. And again, so this is a very good explanation for a blue toe syndrome, or at least if that's the only lesion that we can find, then this is a potential explanation for that. And there's no IMH, as you can see here. So if such a lesion sits in the carotid artery, patient has stroke. If a similar lesion, probably not that big, it sits in the coronary arteries, you can get an MI. Again, that's a ruptured atherosclerotic plaque confined to the intima, resulting in downstream embolic complications. Okay? Now, only if such an ulcer penetrates through the internal elastic lamina into the media, so then it's per definition a penetrating atherosclerotic ulcer. So if this happens acutely or as an acute event, then this can be associated with a focal blood in the wall. So then you have a local intramural hematoma. But again, this is the local version of intramural hematoma, or term meaning that there's blood in the aortic wall, which you can always have if you have an interruption of the luminal surface of the aorta. And it can even get further than just the media. It can even penetrate through the aortic wall entirely and cause a large pseudoaneurysm, or essentially an aortic rupture. So that's a penetrating atherosclerotic ulcer. So the definition is that it's not confined to the intima, but it goes through the internal elastic lamina into the media and then causes either IMH, doesn't have to, but it usually is, and usually causes symptoms. So on imaging, the difficulty is that if you have an image that has a yellow intima, a green media, and an orange adventitia, then you could always make this distinction between atherosclerotic ulcer or penetrating atherosclerotic ulcer. But the last time I looked, our CT images usually give you grayscale images, and you cannot distinguish it well. So the difficulty for us is, or you may wonder, well, but how can I then distinguish between a penetrating atherosclerotic ulcer or just an ulcerated plaque, and answer a clinical question if a patient maybe has an acute PAU? The differentiation is actually quite simple. Or there are just two pieces of information that you need to have to at least call the suspicion of a patient having a penetrating or an acute penetrating atherosclerotic ulcer. Means a patient who presents with an acute aortic syndrome. Number one is if you have fresh blood associated with your lesion, then you know it is an acute aortic lesion, because only for the first 7 to 10 days you will have a hyperattenuating blood, a fresh clot. If you have fresh blood in the wall, it's always acute. And the second piece is the patient also has to be symptomatic. If you have neither symptoms nor an IMH, you can be pretty sure that it's not an acute penetrating atherosclerotic ulcer, but it's either a healed atherosclerotic ulcer or a healed penetrating atherosclerotic ulcer, but it's not acute. It's not an acute aortic syndrome. It doesn't need to be treated immediately. You don't need to call a cardiothoracic or the vascular surgeons. Now let me go again through a couple of examples to practice that. Again, keep in mind, acute aortic syndrome or acute penetrating atherosclerotic ulcer requires symptoms and or fresh intramural blood. Okay, let's start with this patient here. So this patient, 72-year-old woman, she presents with chest pain, and she has a lesion in her descending thoracic aorta, which definitely looks like an ulcer-like shaped lesion. Okay, so my question to you is, can this patient have an acute penetrating atherosclerotic ulcer? And you will say, well, there are two factors I need to consider. Number one, does she have symptoms? And the answer to this is yes. So she has chest pain, and if the chest pain fits and it's kind of sharp and localized, then you could say, well, based on the pain alone, she could have an acute penetrating atherosclerotic ulcer here. And does she have an intramural hematoma? and that we don't see here. So we don't have an intramural hematoma, but she has symptoms that are compatible or consistent with an acute atherosclerotic ulcer. Okay, so the diagnosis here based on imaging would be that you have an ulcer-like lesion or an ulcer in her proximal descending aorta, which in the right clinical context, if associated with appropriate symptoms, could be a small acute penetrating atherosclerotic ulcer. Okay, so that could be an ulcer. Acute. Does it need to be treated? Well, the treatment is again the same as any type B lesion. So unless there is any complications, like it's refractory to beta blockers and pain meds, there's no rupture, there's no acute changes or rapid progression. So it's an uncomplicated descending acute penetrating atherosclerotic ulcer. So the consequence is just to follow it. There's nothing you need to do, particularly if you're not 100% sure that it's a PAU. So this is what happened here. So again, we have a possibly acute PAU, uncomplicated in the descending thoracic aorta. So the easiest thing to do is just follow this. And this patient had a follow-up study just a few days later. And you can see that this lesion changed a little bit in shape, which suggests that at least something is remodeling, something is going on here, supports the assumption that it is an acute lesion. But again, it didn't get larger, it didn't get more, it didn't have sign of rupture, instability, and if the patient is asymptomatic or the symptoms go away, then you can again follow it. And now we have 2 months later, and now you see this lesion here. Now again, now let me ask you, if you only see these images, what does this patient have? On the images, I do see a lesion that looks like an ulcer, right? This looks like an ulcer here, clearly, as it can be. The patient, the question is, does this patient now have an acute penetrating atherosclerotic ulcer? And the answer is no, the patient doesn't. The patient has an ulcer-like lesion. The patient does not have any symptoms. The patient is asymptomatic and has no intramural hematoma. So this is an old ulcer or a chronic ulcer or a re-endothelialized ulcer. And in her, we actually know that she had an acute ulcer before. So at this stage, this is a chronic ulcer. And at this stage, I wouldn't be able to tell if this is a chronic atherosclerotic ulcer or a chronic penetrating atherosclerotic ulcer. And it doesn't have any consequences either. This is a chronic lesion. It's not aneurysmal, so this probably just needs follow-up, if at all. Okay, so that's really the key point. Another patient here, just to stay along the same line. So a patient, 83-year-old woman, she presents with shortness of breath and with pleuritic chest pain. And as everybody who has symptoms like this or no symptoms at all, doesn't matter, everybody gets a PE study who enters the ED here. And you see this lesion here in the descending thoracic aorta. And so my question to you is, does this patient have an ulcer-like lesion protruding from the aorta? And then you could argue, well, she does, and it's actually a pretty large lesion that protrudes off the aorta. So the question again is this an acute penetrating atherosclerotic ulcer? In other words, do we need to call cardiothoracic or vascular surgery to consult with this patient or potentially treat her? And then you say, well, again, the 2 points we have to clarify is she symptomatic and or does she have an intramural blood? And so the symptoms are, I don't know, don't really fit very well. So this is, if you have such a large acute penetrating atherosclerotic ulcer, you would expect some severe back pain or other dramatic symptoms rather than a little bit of a pleuritic chest pain. But again, it's a bit, you're never sure with symptoms if they are bad enough. And then we would also obviously like to see an IMH, because let's say if this was an acute PAU, you would have to see at least some fresh blood around that lesion. Now, where's our non-contrast scan? Well, unfortunately, we don't have it because it was a PE study. And as you know, for PE studies, we don't do routinely non-contrast scans, so that we can't help ourselves with that. So if we needed a non-contrast scan, we would have to wait maybe 5 hours or so, wait until all the contrast is washed out, assuming the patient is normal renal function, then repeat the scan. But the other option is obviously, in this case, we were lucky that we were digging up in the packs and we found some old images of this patient. And now let me show you the patient's image of 5 years earlier. And again, you see exactly the same lesion. So it's a focal outpouching of the descending thoracic aorta. I don't know why she had this scan done back then. It probably was also a PE study, and it has the same dimensions. So this again, so this is not an acute penetrating atherosclerotic ulcer. What we see here is a patient who probably had an acute penetrating atherosclerotic ulcer sometimes before October 2000, and then this lesion healed, it re-endothelialized. And then once they are there, these lesions, they can remodel, they can get a little bit larger, they can ultimately become wider mouthed. And ultimately, if this becomes wider, at some point it may look just like a focal saccular aneurysm. So this is how atherosclerotic ulcers, penetrating atherosclerotic ulcers, aortic remodeling, and AAAs or thoracic aortic aneurysms are related. It's all a manifestation of chronic long-standing atherosclerosis. So again, not all of these ulcers are necessarily penetrating atherosclerotic ulcers. Okay, so now we mentioned we have seen an ulcerated plaque causing Luteau syndrome, and we know that obviously in other vascular territories it can have even more severe consequences. Most plaque is chronic. It can be calcified or non-calcified. You can have chronic ulcers in thick chronic plaque. Then if you have a penetrating atherosclerotic ulcer, only the acute setting is part of the acute aortic syndrome spectrum. And again, you need to have pain and or intramural blood associated with this to make it a penetrating atherosclerotic ulcer. And again, there are also more chronic penetrating remodeled atherosclerotic ulcers or penetrating ulcers than there are acute one. Again, so this, I think, I hope puts it all into perspective and will not confuse you when you look at one of our typical atherosclerotic CT angios and you see ulcers all over the place, and you are worried if you have to call somebody. But again, the majority of ulcer-like lesions that you see in patients with atherosclerosis are chronic, either chronic ulcerated plaque or chronic re-endothelialized PAUs. Now you want to see a few real ones. So here's a patient who obviously has a real acute penetrating atherosclerotic ulcer, or maybe even two of them. There's one outpouching up here, and one outpouching is here. And you see just a little bit of intramural blood. So this is intramural hematoma, just local, where this focal ulcer is. But then you have a rupture. You see hemothorax and a lot of fluid in the left pleural space. So this lesion was then treated with an endograft. So usually descending lesions can be just stent grafted, as dissections do. And many of these patients have a lot of comorbidities, and atherosclerosis usually everywhere. And so endografting is certainly the better treatment than any surgical procedure. So this patient is just from, I think, 2 weeks ago. Again, a patient presenting also with acute chest pain. And you can see here this is just in the distal arch, because here's a nominate carotid. So the subclavian comes up here. So this is on the undersurface of the arch. First, you see a lot of atherosclerotic plaques. This is hypodense. Didn't show now the non-cons, but even the non-cons, this was low in attenuation. So this is plaque on the luminal side. This is thick atherosclerosis in the patient's aortic arch. If we go a little bit further down, you see ulcer-like lesions, again, protruding into that plaque. And if you go even more inferiorly, one of them penetrates through that expected contour of the aorta and penetrates even through the adventitia in the periaortic region. And here you have a reformate, and you can see there are a lot of irregularities and plaque and ulcers in the arch and proximal descending. But here on the undersurface of the arch, you can see one penetrating atherosclerotic ulcer, and on the non-cons, there was a little bit of blood surrounding just this lesion. So that is an acute penetrating atherosclerotic ulcer in the arch. Again, we would call this type B because it does not involve the ascending aorta. Some 3D images just show the same. Here's the ulcer with the little periaortic blood here. This is a view from above. I'm just trying to give you a view down into this barrel here, into this ulcer that penetrated through the aortic wall. There's just some 3Ds just showing you the atherosclerotic disease in this area with this one penetrating atherosclerotic ulcer here. So that's, again, a nice example of an acute penetrating atherosclerotic ulcer. And she was also treated with an endograft and covering the subclavian and with the embolization of the subclavian artery. The treatment, again, as I mentioned, if the ascending is involved, theoretically, this patient should undergo a surgical repair. So if it's a very focal lesion, nowadays people consider an off-label use of an endograft, maybe mainly because all of these patients are usually not great surgical candidates. Again, if there's no complication and not in the ascending aorta, usually they are treated, managed conservatively, but if they're leaking, they're rupturing or growing, then usually need a surgical or endovascular debranching, and I'll show you an example of that as well. And again, the prognosis is not that great if they need to go to surgery because they have quite up to 25% perioperative mortality, which is kind of similar to a patient with type A dissection who presents in shock. So that's also a higher perioperative mortality. Obviously, endografting has a better prognosis, but again, these are usually very sick patients. There's a patient who had also more than one lesion. He had, in fact, a small ulcer here in the proximal descending and a huge lesion on the undersurface of the arch, and then essentially a ruptured aorta in the descending thoracic aorta. So what the treatment plan here was to just treat it with an endograft and ideally cover this huge rupture in the descending aorta, this little outpouching in the undersurface, arch undersurface thing with all with an endograft. And so this was attempted. And I think it worked relatively well because, I mean, mainly this rupture was covered, a little lesion here, but you see the undersurface pseudoaneurysm is still filling here. So, and that it couldn't put the stent graft just more proximally because that would cut off essentially all the supra-arch vessels. They already covered the subclavian artery. So what was done here is what's called an debranching procedure. So what essentially means you try to bypass the supra-arch vessels by using a surgical graft to connect the ascending aorta to the supra-arch vessel. So this is essentially a Y graft or a bifurcated graft, the same graft as you would use for an aortobiiliac graft. And you can suture this to the ascending aorta and then suture the two limbs to the brachiocephalic and the left carotid, and you can do even a carotid to subclavian bypass. And then once you debranch the aorta, so then you can extend an endograft all the way down through the into the ascending aorta. So it's a little bit less, I would say, complicated than do an open repair or an open arch repair, because arch repair is way more complicated. It requires usually deep hypothermic cardiac arrest and antegrade cerebral perfusion, etc. Whereas here you may be able to clamp a portion of the aorta to suture these grafts onto, and you may not need a deep hypothermic arrest if you have to go on pump. Again, this is called a debranching procedure or a hybrid repair. Again, just to summarize here the PAU, so a penetrating atherosclerotic ulcer is defined pathologically as a atherosclerotic ulcer that penetrates through the internal elastic lamina, and that makes an atherosclerotic plaque, an ulcerated atherosclerotic plaque, a penetrating atherosclerotic plaque. In the context of acute aortic syndrome, we usually talk about acute PAU. So that's what is part of the acute aortic syndrome. So acute PAUs are either symptomatic or associated with intramural blood or periaortic blood or IMH or both. But then there are way more chronic, healed, re-endothelialized PAUs or chronic ulcers, and then there are asymptomatic, and those are usually asymptomatic and never associated with IMH. They can be sometimes even large and look like small aneurysms, so they can become aneurysms. But again, they are not a part of the acute aortic syndrome spectrum. Okay, so the final thing, that if I haven't confused you yet, I'll try to confuse you with a final piece of just terminology. And if you take a step back and think, oh, now we heard a lot about ulcers, again, people are not always very specific when they use these terms, but usually the term ulcer alone usually just means that you use this purely descriptive, as it has been used in angio. It's actually an angiographic term that comes from aortography, from catheter angiography, where an ulcer-like lesion or ulcer-like projections was referred to anything that protrudes beyond the expected luminal contour of a vessel. But again, if people talk about ulcer, it can mean just anything. It doesn't have an etiology associated with it. It's a purely descriptive term. If you talk about the penetrating atherosclerotic ulcer, you have essentially, you're talking about a specific pathologic entity, okay? So at least in your mind, you want to separate those and then make sure that you know what you're talking about. But in an acute setting, and if you see ulcer-like lesion on CT, before you make up your mind and tell anybody that it's a PAU or it's just a variant of a dissection, you first have to look at everything else and then can decide if this ulcer-like lesion is just a primary intimal tear in a aortic intramural hematoma, or it could be a branch artery ostium because you see all the other context to it, or it's just a dissection variant communication, or it could be a small limited intimal tear, as you have seen yesterday, or it could also be a penetrating atherosclerotic ulcer, an acute one in the acute setting, or it could be a chronic lesion. But again, if you have the entire context, you will be able to figure it out. But again, one message, not every ulcer-like lesion that you see on a CT scan is an acute PAU. Again, that's what I'm trying to convey on this summary. Okay, so in the final few minutes, another entity that I think should be part of the acute aortic syndromes, and that's this kind of lesion. So this is an 80-year-old patient without any significant past medical history. She presents with an anterior left-sided pain, chest pain, nausea, and vomiting. And I think this is first-year resident level. To see the main abnormality here, that you have a really dilated mediastinum, you have widened anterior mediastinum or superior mediastinum, and you have a very prominent aortic knob here. So the explanation for that on the CT is right here. And let me walk you through a couple of findings here, and then ultimately ask you what you think is the culprit lesion for this patient here. So the explanation for the patient's mediastinal widening on the chest X-ray is that the patient has mediastinal hematoma. Again, look at this. The hematoma is hyperdense, so you have fresh hematoma in the patient's mediastinum. So something is leaking. So something is leaking into the mediastinum, which is usually not a good sign. The other findings that we see is that when you look at the non-contrast images, this is also actually mediastinal. This is probably mediastinal blood here, corresponds to this one here. but she does have a little bit of intramural blood here. So there's a crescent-shaped hyperattenuating zone in the ascending aorta. So she has some blood in the ascending, or IMH in the ascending aorta. Then she also has a kind of a relatively wide aortic arch. So this arches here in proximal descending aorta, they're relatively dilated, relatively ectatic. And then she has also an ulcer in the proximal descending thoracic aorta. Okay, so my question to you is, what is the culprit lesion that causes the patient's mediastinal hematoma? Okay, so here we have some 3D pictures of the same thing. So the reason why you want to know what the culprit lesion is, because you want to decide how to treat it. Let's say if the intramural hematoma in the ascending aorta is a culprit lesion, the patient should undergo sternotomy and ascending aortic repair. If the descending thoracic penetrating atherosclerotic ulcer causes her problem, then you can treat this with a stent graft. If the arch aneurysm is a problem, then you need to do an arch repair, which is a major undertaking that is the most complicated to do. So what do you think is a culprit lesion and needs to be treated? Is it the type A IMH? Is it the arch aneurysm? Or is it the penetrating atherosclerotic ulcer in the descending thoracic aorta? Well, it's not that easy, and I think there was not 100% clear opinions even when we read this study prospectively. You can see, so I thought that the best explanation for the patient's symptoms is a rupturing or atherosclerotic aneurysm, because there's most of the hematoma surrounds the arch, and usually the hematoma is closest to where it comes from. Whereas the intramural hematoma in the ascending aorta is something you would expect with any lesion that affects the integrity of the aorta. So a rupturing aneurysm of the arch can, of course, be associated with blood in the ascending aorta, because it's just a communication between the lumen and the wall can have a little bit of sliver of blood in the ascending aorta. And this ulcer here, to me, looks just very chronic. I mean, there's no hematoma around that area, and this is probably very innocent looking chronic penetrating atherosclerotic ulcer. Maybe it's not even a penetrating atherosclerotic ulcer, so that's innocent. Now, what was the treatment then in this patient? So it turns out that because it's so hard to treat an arch aneurysm, the decision was made to at least treat the descending thoracic aortic penetrating atherosclerotic ulcer, despite nobody was super convinced that it's a culprit lesion, but that's the only thing that they could treat. And so the consequence, unfortunately, was that the ulcer in the descending aorta was treated successfully. You can see here on the autopsy specimen that the stent graft was placed correctly, but then you can see that a few hours after the treatment, the lesion really, the arch really ruptured. Now you can see a huge gash here on the undersurface of the arch. So this was just a leaking atherosclerotic aneurysm rather than a PAU or an IMH in the ascending aorta. And again, when we looked at the 500 patients that we looked between 2003 and 2012, leaking or rupturing aneurysms are more common, at least in our cohort here, than PAUs. So PAUs are not that common, but leaking aneurysms you're going to see here, because this is an aortic center. There are a lot of aneurysm patients who are treated here or followed here. So, and once in a while, they present with leaking or rupturing aneurysms. And so when you look at some of the features, not unexpectedly, if we define them as aortas greater than 4 centimeters and having contrast extravasation or pseudoaneurysm formation, or other findings like local IMH or periaortic mediastinal hematoma in patients who present with an acute aortic pain, then those would be leaking atherosclerotic aneurysm. And here just several examples. So here you see a patient who has, again, the non-cons and post-contrast here. He has a pre-existing aneurysm. And then you see something that looks like a chronic thrombus here, but here the thrombus is also hyperattenuating. So this is probably not what's called an intramural hematoma because it's already aneurysmal, but this is probably just fresh clot or fresh hemorrhage into a pre-existing clot. So this is a rupturing aneurysm. Another example, an interesting sign is if you have an interruption of the calcification, also with a periesophageal hematoma here again on two subsequent slices here. This is how they look. I won't go into any details. I think for you, it's most important just to be able to identify those lesions on imaging. Another situation here, so this was a patient who had in fact an aneurysm or a descending thoracic aortic aneurysm, but the blood was actually tracking along the aorta all the way to mesentery along the esophagus and into here in momentum. Again, the in-hospital mortality is really high in this patient, and the long-term survival of these patients is expectedly also not very good. Here, a more dramatic case, also ascending aneurysm with active extravasation out of this aneurysm into the peri-aortic space and gigantic mediastinal hematoma. So not surprisingly, these patients do not have a very good prognosis. And also, when we looked at the long-term outcomes of our patients with acute aortic syndromes, you can clearly see the outliers, they ruptured aneurysms. They not unexpectedly have very poor survival. So in summary, so these leaking or rupturing thoracic aortic aneurysms are not very common, but they are about as common, maybe even more common than penetrating atherosclerotic ulcers, and they're little more than limited intima tears. So the presenting symptoms are exactly the same as any other patient with acute aortic syndromes. This is why we think that a rupturing aneurysm should also be part of the acute aortic syndromes, whereas traumatic lesions should not be part of it, and also iatrogenic lesions should not be because they are not spontaneous presentations of acute aortic syndromes. Again, acute aortic syndromes essentially should be dissections, intramural hematomas, penetrating atherosclerotic ulcers, and rupturing aortic aneurysms. And again, as for all of the acute lesions of the aorta, we need non-contrast scans to find where the fresh blood is. And the prognosis of rupturing TAAs is worse than any of the other acute lesions that we have. So here just a quick summary, and just to try to reiterate and show you what has always confused me, and hopefully will no longer confuse you in the future. So again, acute aortic syndromes include aortic dissection, then intramural hematoma, PAU, and rupturing or leaking atherosclerotic aneurysms, whereas IMH, you could argue, is not really a true entity, but then IMH usually refers to being a subset or a variant of aortic dissection. So this is why it's listed here and here and here. So most of the time, IMH refers to a variant of aortic dissections, which is when you have cystic media disease and you have the same space that's otherwise filled by flowing blood in the false lumen is filled by clot. That's a IMH as a dissection variant. If very similar demographics, risk factors, they're just a bit older, but the same underlying pathology, which is media degeneration. So the term intramural hematoma as its own entity, I think, is only justified by the fact that the presence of fresh blood just means it's something acute, and you usually need to do something about it, or at least treat them, monitor them very carefully. And intramural blood can also be associated with PAU, but it doesn't have to. And as we've discussed, there are many more ulcers that are not acute PAUs. But again, a PAU is all a factor, a consequence of intimal disease. So they are atherosclerosis, whereas this group is a medial disease. Then rupturing or leaking aneurysms are also an entity that should be part of the acute aortic syndrome. All right. So with this, I'm already done. And that was all there is about acute aortic syndromes. And really, there's really nothing else you need to know. Everything that we covered, it may sound a little bit theoretically, but if you see a few examples of them while you are on call or during your rotations, I think you'll be very well prepped to interpret any kind of acute aortic syndromes in your future. With that, thank you for your attention and open for questions.
Sure, I had asked a question earlier when we were discussing the PAU case. The last PAU case you had was in the arch, and it had progressed past the adventitia, which for me, in my mind, you talked about this hierarchy of the PAU versus kind of progressing to aneurysm or pseudoaneurysm with some sort of rupture. In my experience, the surgeons are more likely to jump when you say pseudoaneurysm, especially if you talk about some leaking of blood, compared to just a PAU, which they might kind of wave off just because they think all ulcers might be a little bit the same, or they don't really think a PAU is on their urgent spectrum in the same way. So I was just wondering what your opinion was on. I think you covered some of that in saying you can still call this a rupturing pseudoaneurysm as your later cases mentioned, but I wanted to kind of clarify that at the time you're mentioning this PAU.
Yeah, that's a good point. So so this lesion it penetrates, as you said, even through the adventitia. So that's certainly an acute lesion and a complicated lesion, and that's why it was treated. So they stent grafted the patient. So she got an endograft, a zone 2 endograft. The terminology is correct. So I think next week or in 2 weeks I'll cover all the surgical topics like aneurysms, etc. And I have some extra time explaining just the term pseudoaneurysm, because that's also very vaguely used, or very, I would say, arbitrarily used. So it's a lot of lingo in there, and there's a lot of there's a pathologic definition, but then there's also a clinical use, which usually is associated with some etiologic factors. But you're right, you could cause this lesion a PAU with a small pseudoaneurysm, or a penetrating ulcer with a periaortic hematoma. I think as long as you make the diagnosis and say that this is a penetrated lesion and it goes beyond the aortic contour, and you can convey this, I think you've done your job. I think that's as you said, the main observation is it gets through the wall and probably needs to be addressed. A good point. Let's just look in the chat for the other question. Okay. Chat questions.
Yes, I had a question, Doctor. This is Armin, one of the body fellows. So my question was pertaining to what you mentioned in terms of the acute PAUs that really are what clinches the diagnosis as having either an intramural hematoma or secondary associated like syndromic pain, aortic syndromic pain. My question was more in terms of like for all these patients who do get their dissection protocols, where I guess assuming that they do have some degree of symptomatology, and given how common ulcerative plaques are in these subset of patients, how do we kind of manage the follow-up? So every time if we see ulcer-like lesions, We don't see intramural hematoma, but they are aortic dissection patients. Do we recommend follow-up on all of these patients, or how do you stratify the follow-up exactly?
Okay. Yeah, I think that's a good question. So I would say that all of the patients that we were talking about the last 2 days are patients with acute aortic syndrome, which means patients who present with symptoms that could be explained by an aortic pain. And most of the patients do not have big atherosclerotic lesions or big ulcers, because the majority of patients are dissections. So they again, the PAUs are only like 7%, 8%. And those patients who have classic dissections, or also the dissection variants, they do not have severe athero. Again, if you to develop a pendulating atherosclerotic ulcer, it's usually you have to have a lot of athero. You often see ulcerated plaques in those patients who have rupturing aneurysms, because they have their ulcer somewhere else, right? So it doesn't really, so it's not a practical problem simply because of how what the patient mix is. So the dissection patients usually don't have severe athero, right? The only group that is a little bit uncertain is older individuals. So you have like 80 years old. So because age is both obviously a risk factor for athero, but also is a risk factor for dissection. So they're very rare cases where I'm not sure if a lesion is a PAU or, I don't know, a dissection variant. So, but again, the treatment would be usually the same. Again, as long as you make the call that it's an acute lesion, I think you're doing your job.
Okay, thank you.
And if you see a lesion and no IMH and the patient is symptomatic, then you just follow them. Just make a follow-up scan in 5 days or before they get discharged.
Perfect. Thank you so much.
Mm-hmm. Yeah.
Does anybody else have any questions? More questions?
Yeah. If you have any other question, you can also always email me or ask me during readout, because I think many of you will have their rotations through the cardiovascular service. I hope I haven't confused you more than before, but I found it always very confusing that the way how these terms are used, and I was never sure what people are talking about. So this is why I try to divvy it apart and really clarify what the meaning of each of these terms can be. So you don't have to use it as specifically, but I think it helps if you in your mind can make this differentiation between those different entities, particularly that understanding that IMH can be a part of a dissection, or it is purely a pure descriptive term. Okay. All right, any other questions? All right, good. So then thank you for your attention, and I think tomorrow we're going to have acute abdominal vascular lesions.